is an important approach in skull-base surgery. It is made to reach petrosapex, petroclival region. We have different options to reach this region. The most simple one is to go retrograde. We have then the posterior petrosal approach, which is more a trajectory to go down, up. We have the anterior petrosal approach, which I will cover now, which is a trajectory which goes from up, down. And we have anteriorly approach through the cavernous sinus, which are more complex and more made for cavernous sinus tumor extending into the petroclival region. And we have at the end the combined petrosal approach, which is used in my practice for large petroclival meningioma. So the anterior petrosal approach is a middle fossa approach. You have to do a temporal craniotomy, peel the dura mater, drill part of this petrous ridge in front of the superior semicircular canal to get into the posterior fossa. The reason why I use this approach, first, petrosapex tumors. If you have a tumor in the petrosapex, it's a great indication. I have to say that most of those tumors now, I go endonasal for chondrosarcoma, cholesterol granuloma especially. I use it also for Meckel's cave tumor, trigeminal schwannoma. For some of those, especially those extending into the posterior fossa, you may need to drill the petrosapex to have a better access, lower access in the posterior fossa. I use it for some petrosapex meningioma, mostly for petroclival meningioma, because for petrosapex, I have to say I use most often retrosig. And I use it for brainstem cavernoma, pontine brainstem cavernoma located anteriorly. Yes, I like this approach. And I use it also sometimes for chordoma, but most of my chordoma cases, I do it through the nose with an endoscopic endonasal for clival chordoma. So it gives you an anterolateral access to the posterior fossa through the temporal fossa floor. You drill the temporal fossa floor, this petrosapex, you expose the posterior fossa dura, and if you open the dura, you are in the posterior fossa. As I said before, it's a looking down approach. It's not an approach made to look up, because the more you look up, the more you need to retract the temporal lobe, and the temporal lobe is the biggest issue with this approach. But the more you drill laterally, the lower you will be able to look down. So this is extremely important to understand this concept. If you look up, you have to retract the temporal lobe more, which is not skull-base surgery. And if you want to look down more, you have to drill more laterally. This is a picture to show you that with a little bit of drilling, with more drilling laterally, and with drilling that proceed until you reach the geniculate ganglion. You see that the more you drill laterally towards the cochlea, geniculate ganglion, you can have access down lower in the posterior fossa. This is pictures drawing from a previous Watanabe, fantastic drawings showing that it's an extradural approach. You have to peel the dura from the temporal fossa. You expose petrosapex, you drill it, you expose posterior fossa dura, you open it, and you have access to the posterior fossa. If you retract more, like I do here, you can look more upward, but then you need, which can be bad. The advantage of the approach is that the surgical corridor do not cross the nerve. What does it mean? When you do a retrosig for a petroclival lesion, you may have to work between the tentorium and 5, between 5 and 7 and 8, between 7 and 8 and 9, 10, 11 sometimes, if the tumor is going far down. If you come with an anterior petrosal approach, you never cross the trajectory of the nerve. You're tangential. Secondly, you get to the dura first, so you can first, which is an important principle in meningioma surgery. You get to the base, you coagulate this, you open the dura, you open the base, and you remove the tumor. Thirdly, you have an exposure above, below the tentorium. You can also have this with a retrosig, but it's a little bit more complicated. You have to open the tent from below. Here you have, before opening the dura, an access the tentorium. You have an exposure to make a valley to the porous trigeminalis. If you're from retrosig, it's more difficult to have such an exposure. You have the exposure of the most posterior part of Meckel's cave, but you don't have this full exposure like you have with anterior petrosal, where you open Meckel's cave like a book. It's an access to the petroclival region, superior on midclivus, and you have an anterior view to the brainstem on the exit zone of entry point of 5. Disadvantage, it's a subtemporal approach and you need temporal lobe retraction, which is sometimes an issue, and you can injure temporal lobe if you are not careful enough. The most dangerous part in this approach is the management of the temporal lobe. So for this, I elevate the thorax, I do a downward inclination of the head. Once I have put my Mayfield like this, the temporal lobe is for a little bit. I use mannitol. I don't use lumbar drain, and I will explain you why after. When you do this extradural peeling, you can have some bleeding, and this is one of the issues. Before Surgiflow and Flowseal, I have to say, when we had only Surgicel, it was quite painful sometimes because those diploic veins coming from the dura going into the bone were disrupted, and it was draining, sometimes bleeding a lot. With Flowseal, tamponade, it's really much easier. Sometimes you can have issues with the vein, and I will tell you more in a second. And it's still a narrow space. It's a complex anatomy. You have to envision the structure on the other side of the cortical surface of the bone. You have to envision the anatomy because the landmark are not 100%. So it's definitely something where you need a good knowledge, strong knowledge of the anatomy. This is the surface of the bone once you expose it, and this is what's under it. This is picture from Rotten. You see how rich is the environment, and there is sometimes only a few millimeters between those structures. So if you don't have this in mind very clearly before doing the surgery, you put all those structures at risk. And neuronavigation cannot save you because it's not precise enough. Before the surgery, extremely important to know the anatomy. It's a bony approach. You need to drill the bone. You have to look at the MRI, CT scan a long time before. You need to spend time looking at this, to look at the shape of the temporal fossa floor, shape of the arcuate eminence, if it corresponds to superior semicircular canal or not, the volume of petrosapex, pneumatization of it, pneumatization of the zygoma, depth of the cochlea. You have to play with the 3D thin cut CT to really put this anatomy into your head, because petrosapex, petrous bone, every anatomy is different from one patient to another. So this is your neuronavigation, and you need to have it in mind before using the true neuronavigation. We published a few years ago this checklist in ACTA that emphasize the fact that there is a lot of things to look at the CT scan, to look at the MRI before starting the case. Failing to prepare is preparing for failure. This is a quotation for Kyu Sung Lee from Seoul, a great skull-based surgeon. I think it's extremely true, especially when you start. So you see here between the right and left petrosapex completely different. But if you know very well this anatomy, if you know that there is those 3 cells, you can open one cell, move to another one, and at the end you can get close to this surface of bone, and you know that you have still 5-6 millimeters of bone before reaching the cochlea. So this is your roadmap, but if you want to use it as a roadmap, you have to read the roadmap before. Same here, you drill the petrosapex, take the cancellous bone out, which sometimes is very soft, and at the end you have this thin layer cortical bone. On the back here, you have this ivory bone. You know that if you drill it more, 2 millimeters, you will get cochlea. I am quite focused on the depth of the cochlea, because if the cochlea is very deep, like here on the right side, it means that you can drill at almost 7-8 millimeters above the cochlea. It's not necessary to drill the petrosapex here if you don't take advantage of this bones that you can easily cochlea. This is also what gives you the ability to go more down, but you just need to be aware that the cochlea is very deep. Here it's the same for the roof of the internal auditory canal. Sometimes it's pneumatized like here. Sometimes it's a thin piece of cortical bone. Most often with the trajectory we have with anterior petrosal and with the amount of retraction that the brain can tolerate, usually it's about 2 centimeters max of retraction. This is the line of sight, the maximum downward line of sight that you can get with the retraction. You here in yellow is the geniculate ganglion. You see that with this line of sight, you're safe. You cannot hit the cochlea, except if you drill blindly in the geniculate ganglion. On the MRI, you look at the specificity of the tumor itself, of the lesion itself that you are treating. Venous anatomy is extremely important. During this approach, you will have most often to cut the suprapetroral sinus. Well, it's important to be aware that sometimes the suprapetroral sinus is not connected to the cavernous sinus, and this is almost 40% of cases. So here, if you cut the suprapetroral sinus here in front of the draining point of the supracerebellar vein, there is no issue. But here, if you cut the suprapetroral sinus here in front of the suprapetroral vein, just here, well, you will cut the outflow for the cerebellum. So this anatomy, you need to be aware of it, how it is, variations, and how it is in your specific patient. I advise you to read those papers for the venous anatomy and also the change of the venous anatomy according to the pathology. There is variation, and there is also variation induced by the pathology itself. Here it shows you the draining pattern of the superior and superficial and deep middle cerebral vein. You can see here that in cases where the superficial venous sylvian vein, drain through foramen ovale, here it's an issue because when you peel the dura and you peel the dura from V3, you can cut this outflow. So venous anatomy is important for those surgery. What is the position I use? Supine, 80 degrees, question mark incision. I monitor the cranial nerve if needed, and I use IME if needed. 80 degrees, 70 degree, 90 degree rotation. It depends of your target. Here, it's a 90-degree rotation for a petrosectomy meningioma. The rotation is too much because naturally, if I am straight, if my microscope is straight, which is good for a good ergonomy, you see that I will have a tendency to drill too deep, and I will drill in front of the tumor base, in front of my target. So for a case like this, it's better to turn less, maybe 60, maybe 70 degree, depending on the target. Then I do the classic frontotemporal incision, interfacial dissection. You need to retract the skin on the, as much as possible anteriorly. Like this, you will be able to retract the muscle as much anteriorly. And for this, you need to disconnect the skin and the muscle. This is why I do interfacial dissection. I don't remove the zygoma. Al-Mefti is removing the zygoma every time, but he is doing that also because he wants to have an upward line of sight. But me personally, I don't think it's an approach to look up, because if you look up, you will need more temporal lobe retraction. I use retrograde dissection of the temporalis muscle. I retract the temporalis muscle anteriorly, and I do a bone flap 2/3 anterior to the external auditory canal. This is the tool I use for superiostal retrograde dissection of the temporalis muscle. You need to elevate the fibers and keep the periostome intact. It's important once you have done your bone flap to shave the border of the bone flap, the inferior border of it, to be exactly at the same levels as the temporal fossa floor. Once you are there, you can start peeling the dura from the temporal fossa floor, from back to front. And then you progressively identify your landmark. Why you need to peel from back to front? Because if you peel from front to back, you may peel GSPN from the bone, and when you reach the fascial hiatus, you will strip the GSPN from geniculate ganglion. You will cut it, and then you have a risk of having a fascial palsy. So this is the bone, the temporal surface. First, I go to look for foramen spinosum. I cut the middle meningeal artery. Then I look for foramen ovale, a little bit anterior and medial to it. Then I go backward again to find the arcuate eminence. Then I look for GSPN, fascial hiatus. I use a stimulator for this. I keep going along the GSPN, and then I look for the petrous ridge. For this, I need to peel the dura from V3. So this is the middle meningeal artery coming out from spinosum. You need to leave 2 or 3 millimeters of middle meningeal artery if possible, because sometimes you have feeders that come out immediately after middle meningeal exit from spinosum, and it feeds geniculate ganglion. I never had a fascial palsy because of that, but there is some description in the literature. Be aware also that sometimes the middle meningeal artery gives the central retina artery through a supraorbital fissure. If this happens, you cut middle meningeal, you can have a blindness. This is extremely rare. But I had a case recently that a fellow of mine pointed me out. And if he didn't told me that, maybe I would have an issue. Arcuate eminence, this is this bulging on the back of the temporal fossa floor. Be aware that there is not always a correspondence between arcuate eminence and the superior semicircular canal. Sometimes it's the superior semicircular canal is behind the arcuate eminence, and sometimes it's in front. GSPN, be aware that GSPN is sometimes covered by periostome, and it's not so easy to identify. There is about 5-10 degrees angle between GSPN and petrous ICA. So petrous ICA is not parallel immediately below. And again, you have to peel from back to front, but not too hard, because if you peel too hard from back to front, you can tract GSPN away from the geniculate. This is a cadaveric dissection. Where is GSPN? Not so easy. Between those bundles of periostome, well, GSPN was here. So this is why you need to help yourself with a stimulator, monitoring of the fascial nerve. Do I unroof foramen ovale? Not necessary. But then you need to peel the dura from V3 if you want to reach the petrous ridge. If you don't do that, you will elevate the dura very hardly, and you will elevate V3 with the dura. So you have to disconnect the dura from V3. For this, you do an incision of the periostome along foramen ovale. This is a cartoon. Blue, red is dura propria, red is periostal dura. So you elevate the dura, you reach foramen ovale, you do this tiny incision along foramen ovale, and you keep peeling the dura propria from V3. This is the principle of peeling of the dura from the cavernous sinus with the Kawase technique. Do I use retraction? This is how I was doing it before. And I was pushing the blade until it reached the petrous ridge to block the blade against the petrous ridge. I have to say I'm not doing it like this anymore. Do I use lumbar drain? No, because I want to keep the CSF around the brain while I am retracting the dura. This CSF is a protection for the brain. If you remove all the CSF before you peel, then when you peel the dura, you directly can injure the brain behind it. So personally, I try to keep the CSF inside as much as possible. I use mannitol, I use reverse Trendelenburg position, and I do a small Dural incision at the convexity. And probably progressively, once I have done the craniotomy, I do that. And then very slowly, the CSF get out. You're still here?
Yes, yes.
Okay.
Of course.
So what I use is dynamic retraction. I am not using blade again. I am using stitches like this. And I put 2 or 3 stitches. And you see that I like to feel the brain pulsating below my section. I really don't think you need a retractor for this surgery, but obviously at the beginning it's more difficult, so it's definitely good to use retractor, and with experience you can try to avoid it. Important also to have a good orientation of your microscope according to your target. When you want to look here, you put your microscope here, but when you want to look deeper, you change the position of your microscope. Otherwise, you will need useless retraction of the temporal lobe. What about the drilling? Once you have exposed Kawase triangles, this is the limit of Kawase. You have V3, you have GSPN, you have superior semicircular canal. There is different volume of bones that you can drill. This is the premeatal space, suprameatal space, postmeatal space, and through petrosapex. Depending on the target, you drill green, you drill blue, you drill yellow, or you drill red, or everything. I start usually my drilling here because medial here along the petrous ridge behind porus trigeminalis, it's very safe. 3 millimeter diamond, sometimes I use coarse diamond, and I push down, get through this cortical bone, and then I make it larger. Then I go towards carotid. Once I have carotid, I go back and drill the bone until I reach the cortical bone of the posterior fossa, posterior surface of the petrous bone. And then I go backward until I reach the internal auditory canal. And then I push more laterally my drilling towards the cochlea. This is the dangerous part when you start, especially because it's not always easy to know exactly where is the cochlea. There is no perfect landmark. And if you need, you can drill the postmeatal space. It's a very tiny space, but it may be nice to expose, for example, the cerebellar peduncle, middle cerebellar peduncle when you want to reach brainstem cavernoma. And sometimes I drill below Meckel's cave, which can be very useful in case of petroclival meningioma. Down, once you have drilled all this and you drill deeper, you expose the inferior petrosal sinus in blue. This is sometimes a lot of blood, especially if it's not a meningioma. If it's a cavernoma, the anatomy is normal, you can have huge bleeding. So once you start to see a blue line, you stop. You don't drill more because it can be really heavy bleeding. This is what I showed before. If you want to go more laterally towards the cochlea, this is more difficult. You have to ask yourself, is it really necessary for what I need to do? And the technique I do when I really want to go very close to the cochlea is that I drill here the labyrinthine portion of the facial nerve. And then I know that my cochlea is just under it. But this is tough. There is really not so much space between cochlea and ampulla of the superior semicircular canal. There is usually around 3 millimeters. So you cannot even put a 3 millimeter diamond in between. What else? Trigeminal nerve transposition. Why would you need to drill the petrous apex? Because if you drill the petrous apex, for example, the true petrous apex below Meckel's cave, first you can coagulate the feeders in a petroclival meningioma more, and you can also create a space in which you can push the trigeminal nerve down, transpose the trigeminal nerve down, and work above trigeminal nerve. We have published with Kentaro Watanabe and Taka Fukushima not so long ago a paper where we wanted to show how you can extend the exposure obtained with the microscope using an endoscope. With an endoscope, especially with angle endoscope, you can go everywhere and extend considerably your amount of exposure. This is drawing from a fellow Gerald Justo that we have now, where he's exploring how you can go through the suture between the petrous bone and the sphenoid and the occipital bone to go into the clivus. Sometimes for a case like this, it's a clival type of a petroclival meningioma. You see that the base is reaching really the anterior clivus until the opposite side. So if we want to have access to the base of this tumor, it can be interesting to drill more here into the clivus. So you have to go on the other side of inferior petroral sinus to have access to the tumor base and to devascularize. Then you have to open the dura. You make an incision on the posterior fossa dura. You make an incision on the temporal fossa dura. You cut the superior petrosal sinus. As I said, you have to cut as medial as possible. Like this, you keep the draining point of the superior petrosal vein, and then you cut the tentorium. You need to cut the tentorium until you reach behind the entry point of trochlear nerve. And this is a beautiful view you have once you have opened the dura of the entry point of 5 into the brainstem. You see down here the inferior petroral sinus, the blue line. If you want to open Meckel's cave, quite easy. You follow here the V3, you cut the ring of the petrous of the trigeminal porus, and you cut along V3, and you can open Meckel's cave like a book. There is issues with this approach. There is complication. Temporal lobe is first. You can have seizure, you can have temporalis muscle atrophy, TMG disorder, CSF leakage, facial nerve palsy, hearing loss. How I close? I close with just putting fat. If there is a big hair cells, I try to put bone wax before, but I close with a big piece of fat. We study morbidity of this approach not so long ago in GNS, and we find out that there is very limited complication, but a few cases where we saw on the MRI on flare. This is the only way to see if you have injured the brain is to look at flare, not at T1 or T1 with gadolinium. And sometimes, yes, we see that there is injury of the temporal lobe. This is 2 cases. I show you this case of a meningioma, petrous apex, petroclival, yes, where this tumor was growing. It's not a big tumor, it's quite small tumors. I thought that it was a good approach to reach this tumor, because if I use a retrosig, I will have to work during the anterior surgery between 7 and 8 and 5. So I look at the bone anatomy. You see that I can drill a lot above the cochlea, and this here is a surgery. So this is a craniotomy. I shave the craniotomy as much as possible to reach the level of the temporal fossa floor. I drill here below the temporalis muscle, coagulate a little bit the dura, put some bone wax here because I open some hair cells, and I progressively drill here below the temporalis muscle to increase my corridor, to have a nice basal view and to avoid as much as possible retraction. Here I find a middle meningeal artery. I isolate middle meningeal, I coagulate and I cut. I try to leave a few millimeters, 2 millimeters of normal artery. I put some flow seal inside. And then I start here to peel from back to front again. Here is V3, tiny incision of the periostal bridge along V3, and I start the peeling of the dura from V3. Kawase technique of the peeling of the lateral wall of the common sinus. I peel, you see V3, you have to be gentle with this because you can injure V3. I cut the periostal layer around along V3 lateral aspect. You see that I use flow seal quite a lot with tamponade, and there is not much bleeding. Here I put my stitches to do the retraction. This is here the peeling over GSPN. So I use sharp on blunt dissection. I progressively expose GSPN, and I find here the petrous ridge. And this is the end of the exposure. I have here Kawase triangle. You see that with slight dynamic retraction, I can expose everything. And then you drill with diamond burr slowly, until you find your structure. You find the cortical bone of the posterior surface of the petrous bone. Here I find the internal auditory canal. I drill the post-meatal space, slowly, slowly. Siga, siga. And here you open the temporal fossa dura. This is the brain. Here you have to be careful when you do that not to injure the temporal lobe. You put cottonoid to protect the brain. And then I cut the posterior fossa dura. Here it's nice because sometimes you have a big flow of CSF. You see, here I have a lot of CSF. So my pressure issue is over. I did this opening behind the meningioma. So there is an easy access to a big cistern. And then I remove the dura, which is the tumor base. And then I cut here the supraorbital sinus. Sometimes I put stitch, sometimes I put clip. Sometimes when the sinus is very tiny, I just coagulate. This depends on what I see on the MRV before. T1 with gadolinium, you can see a lot. And here I cut the tentorium. Here is 5, and here is the meningioma. And progressively, you take this meningioma away. You see that it's very soft, completely devascularized, so quite easy to remove here in this situation. At the end, I wanted to make sure that I would not injure 6. 6 was my fear in this patient. So I put the endoscope inside and I look for the entry point of 6. On this little part of the meningioma, I take it out with my suction. I use chopsticks technique here to look intradurally. I suck the tumor, coagulate a little bit more, but I decide to leave a piece of this tumor along 6 to preserve 6. This is a post-operative scan, post-operative MRI. You see that there is a remnant of tumor along the entry point of 6. Where is it? It's here, and here in the lower clivus depression. I am following this patient. This is an indication for brainstem cavernoma. I will skip it. And this is an indication for Ollier disease. Very interesting chondrosarcoma. So it's a pure petrosepex tumor, nothing to do intradurally. And this tumor was growing. They do a lot of chondrosarcoma everywhere in the body. The tumor was growing. This is this hyper T2 signal. And an option would have been to use the endoscope. But when you look at the CT scan, there is a very long distance of drilling here of the clivus to reach to this lesion. Okay, I can reach it, but can I guarantee that I will take everything out more than if I use an anterior petrosal? No. So this patient, I decided to use anterior petrosal. It was too far through the nose. I show you the second part of the video. Why? Because I did a first surgery. Everything went smoothly. I took the tumor out. It was nice, not very vascularized, nice. The end of the surgery, I put the endoscope inside, chopsticks technique. I take the part that is very deep below the carotid artery under the endoscopic control. Here it is, here it is. I am completely extradural, but I left a piece below the internal auditory canal. And a few years after, it came back. And I had to go back. And this is the interesting part. This is a remnant post-operatively, and this is how it gets. And I went back after 2 or 3 years. You see that the anatomy is the same. Fat transformed itself as dura. Fat is fantastic. It changed its nature and became dura matter like I never came. I do exactly the same technique, but now I know that my remnant is below internal auditory canal. So I have to drill more closer to the cochlea. So here I do a true anterior petrosal approach. Before, I didn't drill above the internal auditory canal. I just drill just behind V3. Now I want to unroof completely the cochlea to have a better access below internal auditory canal. Put a stitch to retract GSPM. And at the end, I put an endoscope. This is the cochlea that I have completely unroofed. And I take the tumor below internal auditory canal under endoscopic control. I use a bended drill, and I use also 70-degree scope to see. Here, I'm getting closer and closer to the cochlea. This is quite tricky. I have to say I was a little bit scared here. But if you go very slowly with a diamond and you stop when the bone is extremely thick and hard to drill, this is the time to stop. But at least I got more exposure below the internal auditory canal. The post-operative MRI was nice. Don't see any remnants, but in early disease, yes, she can recur. I know that. But you cannot use proton beam therapy of radiation as you would like to do it in a patient without early disease, because you never know if you will not have another tumor next to your radiation field. So anterior petrosal is important. Knowledge of the anatomy is key. You have to spend time in the lab. We had Vasiliki with us for a good period of time. She stayed 6 months and she spent a long time in the lab looking at the details of this anatomy. This is absolutely necessary if you want to be confident with this approach. Thank you very much.
Oh, thank you, Sebastian. Thank you. It was fantastic. Your talk, fantastic. And you have opened the, let's say, the door for a lot of questions, comments. You show us very nicely, I must say that, how important is the CT scan, especially if you want to drill around the cochlea. This is very important. You show us very nicely how to peel the dura from behind in order not to injure the GSPN. Very important also, especially as you said in cavernomas and around the middle cerebral peduncle, is to drill the postmeatal trigone, the postmeatal space. Very nice. Also, I think it's very important how to open the dura during the anterior petrosal approach, because you have to cut the tentorium, and between the temporal dura and the tentorium, it's the fifth nerve, the trigeminal nerve, and we have to be aware not to injure the trigeminal nerve. So let's ask for the audience for some questions or comments.
I see that Dimitris is here also. Dimitris Charitos.
Oh, yes, yes.
Hello, Dimitris.
Oh, I don't know. Maybe he's okay. Everybody's here, Sebastian.
Hello.
Hello. Hello.
Vasiliki is also here. Everybody's here. Sebastian, let's have a small talk. For example, if you have trigeminal neuroma of the V1, you think that it's important or it's necessary to take out the anterior cleaning process because it's very near to the superior fissure, or you just do a temporal, let's say, temporal craniotomy?
You mean for a pure V1 trigeminal schwannoma?
Yes, yes, yes.
I have to say it's not so often to see such a pure tumor like this in the supraorbital fissure. Mm-hmm. I don't remember I have done one with surgery, a pure one. I prefer for the small lesion like this to use radiation therapy and especially radiosurgery, personally. So for trigeminal schwannoma, I use it. I treat only big tumors. Mm-hmm. The one would goes into the posterior fossa with a big tumor in the Meckel's cave, sometimes extending into infratemporal fossa. I have done cases through the nose when I have the feeling that the tumor is soft, but still it's difficult with the function of 5 because it's tough to predict where will be 5 fibers when you come from the nose. It's the same with transcranial approach. Mm-hmm. I found it always difficult to preserve trigeminal nerve. So I'm not trying to achieve a complete resection. and I'm trying to be as careful as possible with the trigeminal nerve function.
Yes.
I think we don't have the answer yet for trigeminal schwannoma. There is different types of tumors. Some are growing rapidly. Some produce symptoms before the surgery. Some you have very limited symptoms. And the goal of the surgery is not only oncologic, it's also a question of pain. If the patient has pain before, what is the best way to control this pain? It depends if it's a neuropathic pain or if it's a trigeminal neuralgia because of compression. And secondly, if you do surgery, what's the best way to preserve function for patients which are most often asymptomatic before the surgery, at least with trigeminal function? So for me, trigeminal schwannoma is definitely a challenge. I have done cases with FTOZ approach where the tumor is huge, frontotemporal approach or anterior petrosal. It depends of the extension of the tumor.
Yes, and I think it's very important to have in mind not to take all the tumor out from the V1 or the V2 because we have a lot of complications just to leave some tumor there. I think we all agree on that. Sebastian, if you have a petroclival meningioma, would you suggest to do an anterior petrosal or posterior petrosal approach?
For a small petroclival, if it's not going far down like the one I showed, yes, I can do anterior petrosal. I have a case tomorrow. The tumor is not very far down. It's very going deep into the brainstem, into the peduncle. The patient has a strong brainstem symptoms, but it's not going down. And this line of sight is great for this part of the tumor because the brainstem is pushed posteriorly. It's not pushed on the other side. That is great. For large tumor, big ones going up.
Yeah.
But with the brain pushed more laterally, I use combined petrosal because I want multiple line of sight. I want this line of sight from down, up, from behind, temporal line of sight below the temporal lobe, a line of sight between temporal lobe and cerebellum. I want these multiple angles to work on the tumor.
That's right. And when you have a brainstem, let's say a brainstem, let's say a pons and an anterolateral pons cavernoma, you think that is it possible to use an extended retrosigmoid approach and just open the petrosal fissure? I think you can reach there. Yeah, you don't.
Yeah, I think it's possible. I definitely think it's possible. Again, it depends on the topography of the cavernoma. You know, how deep he is in the brainstem, how close he is from the surface, if he's bulging a little bit or pushing the anterior surface of the brainstem anteriorly or not. I have to say I like this line of sight for cavernoma because you really come from the best angle. You have a perfect control of your field. You come from anterior. You have control of 5. You don't take any risk with 7 and 8. I like it.
That's great. And yes, of course, for Meckel's cave it's a very nice approach. Very nice approach. If the tumor is small, and I have one case for a small meningioma of the porus trigeminus, it has reached the temporal fossa, but most of the tumor was in the posterior fossa. So I decided to do an extended retrosigmoid, but it was small tumor, and I didn't have any problems. I considered it's better to go down than to drill all the petrosal, the petrous apex bone. So when you drill the petrous apex, you say that you start from the, let's say, from the edge of the petrous bone, and then you go up where the petrosal carotid is. Yes.
Yes.
And then you go toward the internal acousticus meatus, yes?
Yes.
Okay.
That's about how I do it. Yeah.
Yes. And you don't open the. Do you open often the premeatal space, or you don't do that? I mean, it's a lot of drilling if you drill also the premeatal space.
You mean the postmeatal space?
The postmeatal, yes.
The postmeatal space, it really depends. If it's a petrosapex tumor, there is absolutely no need. If it's a petrosapex meningioma with a wide base, yes, it can be useful. And sometimes I have done it recently, not so long ago. Don't remember the case, but I know I have done it. You can even drill the superior petroral sign, the superior, if hearing has been lost already. And in fact, the ENT have been the first to describe this anterior petrosal approach for ENT tumors, for schwannoma, in fact. And they have described a translabyrinthine approach from above, where they do this subtemporal approach, and they drill the petrosapex, but they also drill the superior semicircular canal because hearing is lost. And it gives you a lot of exposure. So it really depends on the situation, extension of the tumor, hearing function or not. There is multiple factors.
And you stop when you feel that you are in a cortical bone, yes? When you are in cortical bone by drilling, then you are sure that you have reached the meatus, yes?
Yes, especially if you have a good idea of the thickness of the cortical bone looking at your CT scan preoperatively. Yeah.
That's right, yes. So very nice, very nice.